Hello everyone. This is our discussion on transplant. So it'll have some content on immunosuppression again. This should be a little bit of a review, but also we'll just look at some select organ transplants and their interventions. We'll also look at organ recipients and donors. So let's begin, and this should be about an hour, maybe a little bit more of content. Here's our excuse me, here's our objectives. Those are right from your objectives and readings. And let's go ahead and begin. You can just take a minute and look over those, or look over those from your objectives and reading. So organ donation. Here are some general overview and issues from organ donation. Our most serious concern is lack of donated organs. We usually have with organ transplant, there's typically so many organs that are transplanted a year, but there's usually twice as many people who need organs than are available. And you'll see that for that, 1/3 of patients on the list for specific transplants don't live to get an organ. The organ donation organization is UNOS, United Network of Organ Sharing, and there is the link or the website for them if you're interested. It is a very interesting website to look through. If you have a minute, that would be fine. It's not required. But other issues involved with organ donation include controlling the immune system. So we just have talked a little bit about the immune system in the previous content. And it is controlled through anti-rejection medications. And if you remember from NRS 322, last year we talked about this as a type 4 hypersensitivity, which of course you immediately don't recall what that is, but that's a cell-mediated immunity where the certain white cells, neutrophils, T cells or B cells, identify that the substance is foreign and attacks. There are some ethical issues that appear in organ transplants, and some people are interested in being donors but are afraid of the risks that it brings, as far as, it's a major surgery if they're doing a living donor. If the recipient doesn't make it, sometimes the donor feels bad. Is there something I did? Is something wrong with my organ? And then if we have like a big extended family and there are pressures from family members for everyone to be screened and see if they can give an organ, and maybe the person who is reluctant to be screened matches and now they really don't want to give an organ, so it can cause family and informed consent issues. So the organ transplant team is usually very careful about screening people and making sure they self-identify that they truly are interested in participating in this. There's some barriers to donation as well. If the donor has to miss work, they could miss income from that. Not all companies will cover that. And there are some insurance concerns about donation. So all that has to be checked out in advance and make sure that everything is acceptable before organ donation can occur for a living donor. Types of donors, and we just mentioned living donors. So those would be where you could take a piece of or a duplicate organ or part of an organ and donate it to someone. The donor lives, the recipient hopefully lives and recovers and does well. But you can see the living donors could be related or non-related. People might just be on the, be the match or have themselves identified for a possible match. It could be non-directed. There have been individuals who have appeared and have identified that they have 2 kidneys and they would like to give a kidney to someone, and they don't care who it is. It's got to be someone who really needs it. There are some paired donations. You probably have seen those in the media, and this would be the format of I need a kidney and my child wants to give me a kidney, but they don't match me, but they maybe match someone else who needs a kidney and their family member matches me. So now we have a situation where my family member will give a kidney with the expectations that I get a kidney from someone. And sometimes the pairings can be like 50 and 60 pairs of people, and it might take a good year or more to work through all the pairings, and thus far nobody has backed out of this situation. I think people are very altruistic and want to do well and see that the difference it makes for their family member. So if you go to unos.org, I think in the web links there might be a little New York Times article that I put in there. I'll try to check to make sure that it's still there about paired donations. Cadaver donors then are can be used for any type of tissue, which would be like heart, lung, liver. Any of the donations could be made off of a cadaver donor. And there's two types of donors, and we'll look at those in just a moment. So there are living donors, and living donors have started, and you see quite a while ago, it was in the 1950s, when they realized that they could do kidney transplants. And they just have to be well matched. They take some time to make sure that there's good blood typing, there's good human leukocyte, I think it's antibody or antigen, no antibody cohesiveness, so that they're well matched. And you can see there's good advantages to this with a really strong match. Instead of a good match, there can be better life of the donated organ, but you can see that it's immediately available. It will be in good health. But the individual donating will be in one operating room suite. The recipient will be in another. It can be scheduled, so you make sure everyone's in their best physical health. Also, there are several types of living donors. You can see that a lot of this arose from the need for donors for children. So particularly, it's difficult to have childhood transplants. But with livers, you could take a piece of a liver and do that. And certainly there were others that evolved from this beyond just the liver. And these are not for children, but for everyone. So for cadaver donors, the cadaver donor could be either from cardiac death or brain death. And we typically see brain death as a cadaver donor. The reason is the cardiac death could be sudden, and then perfusion to the organs might be disrupted enough that the major organs might not be viable. So it says death is determined by lack of heart activity rather than brain death. So if it's less healthy, since if there's no cardiac output, then there's lots of ischemia to the tissues. So it's typically more tissue type of donors. You see their skin, cornea, bone, heart valves. The organs that can last a little longer due to ischemia, liver, lung, kidney, those can be used, but the procurement team that actually takes the organ needs to be in the same institution or quite close by. And then the other thing is the recipient almost has to be in the hospital awaiting transplant. So there's a few hours in between the patient's cardiac death for the donor and then the recipient's transplant of the organ. Now, brain death is much more common, and the reason for that is even with brain function disrupted and the patient no longer having brain function, for a while the body can still function and be supported, so there's good blood flow to the kidneys, to the organs. So you can see the key to that is to identify if the person truly has complete loss of brain function. So the patient should not have CNS sedation, which would cloud the assessments for brain death. They can have no sedation, and they should not be in a hypothermic state, which slows down metabolism and then also blunts the testing for brain death. They should not have any spontaneous respirations if they're taken off the ventilator, and they should not have any cranial nerve reflexes, because the cranial nerves arise from the brain itself. And you can see some of those nerves, the cranial nerves, the pupillary responses, the corneal reflexes gag, painful stimuli, they don't do anything. There should be no spontaneous movement. Some confirmatory tests for brain death. And there are a couple that will be employed. One is the apnea test, where the patients are allowed to not have ventilatory support, and they watch that their PaCO2 rises up to 60. Now, even with some pulmonary disease, once a person is at 60 or above, they definitely should have a reflex respiratory response. If none, that means their respiratory centers in their brain stem are not working. So that would be a confirmation. They could do blood flow studies. I've got a slide. The next slide will show some of that. That can do transcranial Dopplers, angiograms, and it just shows that the blood flow to the brain has ceased. And the EEG can also be used, and the rule for that, and you can see the kind of the electrocerebral silence, which is like the second half of the tracing there, which is kind of flat. You see activity on the left, and then you see everything go flat on the right. The key to that would be one EEG is not sufficient. They would wait 24 hours and do a second, and that would be your confirmatory test for lack of brain activity. And then here's the little bit of cerebral blood flow studies. You'll see the normal, and not a great picture, but you would see all kinds of vascularization up into the head, into the brain. But if the blood flow studies, you'd kind of see a cutoff into the entry into the brain. So you'd see no activity up there. As far as potential donors, what we're looking for, and this would be for brain death, there are certain presentations that are identified, and that would be any acute head trauma, a lone intracerebral bleed due to either a CVA or an aneurysm, and then anoxic encephalopathy. You can see someone who's undergone CPR for a long time and has been brought around but has no brain function, or if there's a primary brain lesion with no metastasis. So there are certain brain lesions that don't have metastasis, and then there are benign tumors that grow and just can kind of crush the brain contents if they're not relieved. So all of these would have to be carefully evaluated for lack of brain activity. Certainly you can have an aneurysm and then go in and patient can be salvaged. They don't allow aneurysm patients to die just so they have organs. These are patients that are beyond saving, and they've already made some attempts to save the patient. A few other types of donations would be xenografts. These are animal organs into humans. Very few of this is done in the, I'm going to say the 70s, maybe the 80s. There was someone who was doing baboon hearts into babies as a bridge until they got a real heart. And they only did a few of these. The concern was there was just such an overwhelming immune reaction that I think in one of the children, they had their baboon heart for a week or a week and a half and were able to find a donor. But the other ones, that the rejection was too much. So you can see we have hyperacute rejection. There's some animal viruses that can come into humans, as we well know. And then also, what about the rights of the animals as well? So very little is used for that. The one exception is the heart valves. They can use pig valves for that, and that's been widely used for a long time. I don't think it's used as much anymore because they have good mechanical valves. Here's some facts. Transplantation began in '62, but really took until '82 for a lot of debate regarding what is brain death and what is life, and all the different laws were finally enacted in 1982 regarding the uniform determination of death. So it was used before that. The criteria is really strict, and it was more difficult to transplant, but there was agreement on a legislative platform in 1982. So you can see that the guidelines are outlined in the Uniform Anatomical Gift Act, and there are some organizations responsible. The major one is the United Network for Organ Sharing, is for the U.S. And we have a local one here, which is Gift of Hope, which is what we call our regional center. So you can see what the responsibilities are. A lot of it is keeping lists, making sure the policies are equitable as new interventions or new options show up. It's like, where does that fit into the scheme of things, and what are the policies for these? And again, there's our link to the UNOS. Our local organ procurement organization, OPO, that is Gift of Hope. So that's a regional organ bank. And this implements the guidelines in our area. So I think our area, don't quote me, is like Illinois and northern Indiana, and then into lower Wisconsin. Don't quote me on all this, but it's the whole region, and the region is based on how long it can take to get an organ to a transplant center. So where the individual organ is that's being donated and where the recipient is. So it keeps a list of all the local recipients, and those are also handled through the organ the organ transplant centers keep lists of their patients and who they're working with. You can see that minimally they need the organ, the type, the weight, patient, the height. And that's important if you're working with like adolescents, a 12-year-old or 10-year-old. They're all different shapes and sizes, but also with adults. So if I would need a heart and one becomes available, and it's a heart from one of the defensive linemen from the Chicago Bears, it is not going to work. I'm not going to be able to get that size of a heart into my chest cavity. So height and weight more than age regarding the organ. You can see blood type, but there are other matching criteria for, if possible, as far as their white cells. They also keep each individual hospital, I know, has an organ or transplant team that meets every week, and it is like the transplant team for the heart and the transplant team for the kidney. They tend to all meet as a group to go over who's still waiting, what their condition is. Sometimes it's like so-and-so passed away this weekend, so they would be off the list, or so-and-so has not shown up in clinic for a while. So what are we going to do about that? So lots of information, but those are the major criteria kept on our organ transplants. Gift of Hope. And you can see, it's the northern two-thirds of Illinois and northwest Indiana. So I lied about Wisconsin. So here's our different departments, which you don't have to really know about. And then here's our transplant centers. And you can see it does reach down into Springfield and into Peoria. And just quite a few up in the Chicago area. And not all transplant centers will have all transplant options regarding the organ for the patient. So barriers to donation. Some are concerned that, well, I'm healthy, I got good organs. Will people make as much effort as possible to keep me alive? So some of those fears, there are really no specific religious beliefs saying that this can't happen. However, as religion was developed in ancient times, I don't think anyone would ever anticipate this would be our current state of organ transplants. Sometimes people don't go on the list don't go on the list to donate because they're just not comfortable talking about the possibility of their own demise. Families might be concerned there really isn't any cost of donation. They're also concerned, they don't want their family member mutilated and I want an open casket. Really, all organ transplants can have open caskets. The organ procurement team is very careful with that. The big barrier to donation would be, too, if people are approached too earlier, and it does look like organ hunting or organ shopping. Some families are very convinced that where there's life, there's hope. The other thing is, if you have signed on your driver's license that you are a recipient, that's kind of your final say on things. It might get a little interesting as far as approaching the family, but the families always have to be approached in a respectful manner at a time that they have decoupled. And we don't do that. We can certainly talk to if the family says, they've always been the kind of person who wants to give, and they've talked about donating, who do we talk to? That would be very acceptable for us to translate that. Usually the physician discusses transplant options with the family, but the family has to be at the point where they're seeing it as an option and they don't see recovery as an option, and that's decoupling. Their beliefs of cure and rehabilitation are no longer viable, that they're looking forward in the manner of the patient. Their family member won't be there for them. So some nursing roles, and that would be identifying potential donors, but you identify them to the team or the primary care provider. We want to be an advocate to the family, a lot of listening, a lot of therapeutics. Make sure they're talking about the patient will want this, and it's a way of them continuing because they know they're not coming back. What their emotional needs are and religious beliefs are. We've had patients who have told us their family will sit up in the casket and walk out of the funeral room because they just are so believing that, or unbelieving that their family member cannot pass away. And these are usually with young family members. It's difficult to see. We can't convince them otherwise, but we just have to be there for them. Organ allocation, again, it has to be a good match, the best match, and how close the organ is to the recipient. So there might be really two great matches, but one might be an hour further away. They're probably going to allocate the organ to the closer one to make sure that the organ is in best condition. So that would be proximity. And then we go back to like all the matches. Is it a good tissue match? Is it a good blood type match? Some tissue typing. So we have the histocompatibility with the human leukocyte antibodies and the ABO, what blood type they are. So it might be that if this is kind of an urgent transplant, they might not be able to do all the HLAs. They can certainly do the blood typing. Living donors allow for just much more thorough testing. And when we're looking at which tissues react and therefore need the best match possible, bone marrow needs a really, really strong match, as does skin. And this would be then pancreas, heart, liver, and kidney. Liver is most forgiving, so they don't have to be as exact a match. And the transplant can still go well. As far as donation, so these need to be healthy individuals. They have to have their organ preserved. So once they're declared brain dead, they are actually supported through ventilator and through IVs and medications to provide enough oxygen and cardiovascular function for good tissue perfusion. Age is not as much a factor as the quality of the organ, so a real vigorous 72-year-old who wants to donate can certainly do that. Even as people age, they can donate tendons and bones and other types of non-organ transplants. Here's some of our other qualifications. No cancer in the last 5 years, other than a primary brain tumor without metastasis, or the superficial skin cancer. So if you recall, that would be basal cell or squamous cell. No infection, no sepsis, no communicable diseases, no IV drug use. So a couple of years ago, there was a horrible transplant disaster. I think it was South Carolina. A young man in his late 20s dies, and the wife gave permission to use the organs, and then maybe a month later, one of them dies of rabies, one of the recipients. And it was like just panic for the rest of the recipients. And when they talked to the family, the wife later, they're like, yeah, he was out hunting in the woods for 2 weeks, came back, and a couple days later, a week later, he got really sick. No one could ever figure out what was wrong. So they didn't figure out rabies until a recipient died. All the other ones were okay because they had to get urgent rabies shots. So they had transplanted a communicable disease into everyone. No IV drug use, just to make sure we don't have any HIV virus. We're being transplanted while it's in the undetectable period. Management of the donor after brain death, and you can see it's kind of an intensive care that's provided. So it's to preserve the potential organs, and you can see it's all about glucose control, temperature. No, a person just can't be held for like 3 weeks until they get a good organ recipient. It's 24 hours or so. That's about it. Because once the brainstem is gone, there's no like master control of all these functions. So the temperature is going up and down, and the blood pressure is crashing, and too many meds are being put on board to really have a healthy tissue for the transplant. So this is what is monitored, and the transplant tries to happen as soon as possible. They will allow the family in the room as they disconnect them, and then they immediately roll them down to the surgical suite. They say their goodbyes. Recommended evaluation for recipients. So they want a good history and physical. They update that, keep their immunizations up to date. They do good lab screenings. You see those there. They want to make sure they stool guaiac or hemoccult ×3. They want to make sure there's no occult bleeding, which would say maybe some underlying colon cancer or something. And they do as much like how healthy are they and what do they need to work on while they're waiting for transplant. Some other recommended evaluations, it's a full physicals. Dental examinations, dental caries or cavities can cause lots of underlying infection. How are they doing psychologically? They're going to have someone else's body part keeping them alive. And then financial, there are issues as far as the cost of the transplants. You can see now this is a couple years old. It was about $250,000 for an uncomplicated kidney transplant, which are fairly easy. And it's not like after a VA everything's fixed. They have to be monitored. They have to look for rejection. They're on lots of medications. You can see it could be substantial. So there are some contraindications to becoming a transplant recipient. And you can see it sounds weird, but end-stage organ disease is like, isn't this why they're getting a transplant? But it would have to be, potentially an organ that's not transplantable. It could be especially with livers, if they get too diseased and they're affecting multiple other organs, they would be taken off of the list. If there's hematologic disease, infections, you can see the list of those. Severe osteoporosis, because some of the medications cause even more osteoporosis. If the person is deemed to be have some instability where they would have difficulty handling a transplant and all the issues that go with that. Age, you see the age there is less than 65, but it's evaluated on the person's health. And then if the patient is going to be compliant, so they can tell if they're in the if they're in the transplant program, if they're not showing up for appointments or blowing things off, or if they've been told to start exercising, it's like, yeah, they have to look at that, because basically they're getting a gift and they have to care for their gift afterward. The recipient, once the transplant organ is ready, they'll be called to the OR. If they're sick, they might be in the hospital waiting. And you can see the surgical team is separate. There's a donor, someone waiting to transplant the organ into the patient, and then there's also the donor surgical team. And what happens typically is, if this is a brain death and there's multiple organs, and not all of the organs are going to the same transplant center, each transplant center will have to send out their organ procurement team, and then ice pack it, and they pack it in saline or whatever the solution is. They pack the organ in, and then in ice, and they transport it back to the hospital where the patient is. So all that's done by the specific transplant center team. So there might be 4 different teams that are working on the patient, the recipient, in different orders. Because if the University of Illinois is getting the heart, and the rush people, take the heart and do something wrong, that's what start World War or whatever for the transplant center. So each team typically sends out like if it'd be heart, they send out the cardiovascular surgical fellows who are beyond residents, and they're doing a more intense practice for the cardiovascular transplant. So they're sent out to do that. You can see the organ-specific ischemic time. So if a heart is to be done, it's really helpful if it's in the local area, and lungs as well. But you can see if you have a kidney or a liver, those can be like out in the borders of the, further out in the state, or can be, we might have a patient that's up in the Rockford area that could easily go down to Springfield. So different ischemic times for best function. As far as rejection, there's a couple of different kinds of rejection. All organs start rejection because it's not the person's own tissue. So you can see there's a hyperacute rejection. Now this is very rare. It is typically in the kidneys, which is very helpful. And the reason is, if the kidney hyper-rejects and has to be removed immediately, they can go back on dialysis. So the patient will be very disappointed, but they will live. So you can see there's a big immune response. Immediately they see very pale, ischemic kidney. And you can see there's been some incompatibility, or perhaps this person's received a lot of blood transfusions, they've had multiple pregnancies, they've had previous transplants, and their cells are just very sensitive to any new tissue. Treatment would be removal of the organ because it's going to be non-functional, and again, this is kidney. Acute or chronic. So we have acute rejection, meaning not hyperacute, but this is occurring fairly quickly after transplant. And it is because the body's own cells are responding to this kind of non-self that's appeared in their body. So the treatment is to do surveillance regarding the rejection, watch for signs and symptoms of rejection, then add additional therapy. Everyone is immediately on anti-rejection therapy, but they would have to maybe play with it, add more, increase the dose, whatever needs to be done. Chronic could occur progressively over the years. It's going to. So every graft ultimately will fail. It might take 15 to 20 years, but it will have some graft rejection. And you can see how that works. The antibodies cause kind of the scarring of the tissues. There's ischemia and then failure. And again, it's all about good anti-rejection medications. So the balance is to make sure the patient has some immune system left, not too much that they're getting into rejection, and also that the side effects of the rejection medication aren't bothersome for the patient, so quality of life as well. Here's some of our complications other than rejection. Obviously infection. So here's our goals. Good patient education, teaching them signs and symptoms, take their temperatures, watch for specific signs and symptoms based on the organ that's involved. And factors are related to immune suppression. Is there too much immune suppression? Who are they around? What kind of pathogen exposure do they have? And then also, if they're using too many antibiotics, that could be causing some infections that have developed resistance to some of the antibiotics. So we have to be real careful with them. So here's some major guide to immunosuppression, which sounds like our patient that's like on chemotherapy, or our patient that's had radiation and has their immune system down. So much of this is related to what we're going through right now. However, with a person with transplant, we have to watch for a few other things. They shouldn't be taking care of animals. We talked about emptying the cat litter before. Animals can carry different little parasites and bugs and infection things. Usually don't get to people, but we have to be careful with that. Avoid working in the dirt. There's all kinds of normal bacteria that are in the dirt, so they should wear gloves. They probably should wear a mask as well. Wash the hands. And here's some food habits about raw food, seafood. Cookie dough is a big no-no because usually there's raw eggs in it, unpasteurized eggs. And there is cookie dough that's made with pasteurized eggs that can be ingested for people that have to have their cookie dough. No rare meats, no sushi bars. Wash fruit before peeling and eating, so just be real careful with the fresh fruit. But no raw vegetables. It's very, very difficult to clean cauliflower and broccoli with all those little florets on them. And you can see salad bars and well water. So they should have some purified source of water or a little purifier on their faucet. In the hospital, they do try to eliminate flowers and plants because there's dirt in there, and there's could be things growing in the water on the plants. They're careful with the showers because of all the splashing. If they do use showers, they have to be cleaned really carefully between patients. It should be a private room, that should go without saying. And nursing really shouldn't be jumping between an infective person and a transplant patient. Preventing would be hand washing, but really here's our treatments: antibiotics, fungals, antivirals, update on the vaccinations, and actually dental hygiene is very helpful. So flossing, brushing every 6 months for their dental checks and cleanups. It's a good source to get directly into the vascular system. Some other complications. Hypertension is very common in organ transplant, and the main reason is the anti-rejection drugs, especially the two you see there, cyclosporin and prednisone, are particularly pose the risk of hypertension. Other complications, malignancies. So this chronic immunosuppression feeds back into the theory that cancers are related in some way to the immune system. So as the immune system is suppressed, any underlying cancer genes can be activated, and you see the type of malignancies that show up: skin, lips, cervix, lymphoma. And this is kind of the same with our HIV patients. We saw additional types of cancers in that population. We've got a couple of anti-rejection medications to look at. So here's the goal. So we want to make sure the graft or the organ stays healthy. while providing enough immunity and by watching white blood cell counts to prevent infection. So you can see without any immunosuppression, 2 weeks, and that was it. So medications are really combined. There's some medications that are given right in surgery. It's called induction therapy, where the individual is given IV anti-rejection medication in the operative suite. And then we're just going to touch on a couple of the common ones. Prednisone is very common, and we see that in all kinds of different applications, and we'll talk about a couple others. But there are new anti-rejection meds constantly that are being examined. These are the ones that are more likely to appear on like an NCLEX type of question. So here's some of our nursing interventions, regardless of the therapy, if they're going to produce immunosuppression. So here is, good infection control prevention measures. I'm sure you've heard all of these. Monitor for the signs and symptoms. Watch the vital signs, especially the temperature, white blood cell counts. It might be inspecting oral mucous membranes to see if there's any thrush or any infection starting there. Good oral hygiene, and then watch their drugs and drug therapy. Make sure as you give patients their drugs, any drug, you kind of take advantage of that teaching moment. This little white one is called whatever, hydrodiarrhea, and this is here to do whatever to you. So make sure, especially with these, that they get good information about their medications. Side effects of immunosuppression. Hydrodiarrhea obviously is a diuretic, and I just pulled that one off the top of my head. It's not an anti-rejection med. Here are some side effects. And we talked about hypertension. So indeed, they might be on their immunosuppressants, and then add antihypertensives. Side effects of immunosuppression. Leukopenia, very expected, and we're hoping it drops, but not precipitatively. Kidney function, so we'd have to watch the kidney markers, lab markers for that. Osteoporosis, they might have a bone density scan to begin with and go from there. Some of the medications can cause diabetes. Prednisone will cause hyperglycemia. Prednisone also stimulates the appetite, and they might end up having problems with obesity. Sexual dysfunction and impotence, changes with their eyes. Some of them provoke cataracts, and then cancergenesis due to the immune suppression. So let's look at a couple of the meds. Here's the glucocorticoids, or we've seen these before. Anti-inflammatory actions, and here's the drug during maintenance, the mechanism of action. So we have a couple forms, the methylprednisolone or the methylprednisolone or the prednisone. And as you recall, chronic use is going to give you lots of side effects and increase the risk of infection. So any of our patients, regardless of transplant or not, will have problems. So make sure you're aware of those. Another one is the calcineurin inhibitors, which are cyclosporin. And these were, I believe, vital to continuing heart transplants. They were having a lot of trouble with heart transplants. They just didn't have a great survivability, months, not years. Now they're like 15, 20 years. But the meds they had at the time just weren't helping and weren't providing good immune suppression. So cyclosporin showed up, and it was very, very helpful. Unfortunately, it does do side effects of hypertension and nephrotoxicity. It's incompatible with many drugs, but it really, really extends the life of many of the transplant patients by only targeting the T cells and allowing the host to continue to have some immunity to function, ward off infection. You can see the T cells, however, protect against viral infection, so they would have to be careful with any viral diseases and disorders. Some cytotoxic agents, this would be mycophenolate, mofetil, or you'll see that as CellCept. This is an oral medication, and you can see it affects the T and B lymphocytes. And this is, I see this a lot in clinical with our patients that have had like kidney transplants. They'll be on CellCept and maybe a little bit of prednisone. They do pretty well. So it's the bone marrow suppression, which is what we want, neutropenia, what we want. And what they'll do is they'll watch the dose and get the white count to between 3 and 5. And the normal white count, if you can recall, is 5 to about 10. So what are they doing? They're just trying to be optimal below that 5,000 without being so small that they're going to be in danger of major infection. Another one would be the monoclonal antibodies, the orthoclone OKT3. You can see that it targets specific antigens and T-cell recognition. So this is a medication that's given during the operative phase or post-operatively. And you can see it really does a number on the T-cells. So the side effects are that cytokine release syndrome that we've seen in other monoclonal antibodies, fever, malaise, rigors. And as we talked about before, we can use like pre-treatment, acetaminophen, the antihistamine, diphenhydramine or Benadryl, and prednisone. It does seem to be linked to a higher incidence of lymphoma, however. Additional meds, sometimes they're on the antiplatelet aggregate, just a baby aspirin a day. Obviously, antihypertensives, calcium supplements if they're starting to have renal disorders, our Fosamax and Protonix, but our Fosamax is alendrolate. Sorry, Fosamax is the trade name. But alendrolate is it's a bisphosphonate for bone strength, so that would be for the osteoporosis. And then Protonix, again, is one of our H2 inhibit. No, that's not. It's a PPI. So lots of additional medications possible. So let's look at a couple of our specified transplants. So we have number one is a kidney transplant. And this is treatment for end-stage renal disease. You can see all the different possible causes as we've talked about in renal disease before. Also, retransplantation. So sometimes people have kidney disease when they're younger and they might need a second kidney. We talked about the expense before. This is one of our simpler transplants, actually. And you can see this is a good option for children with severe kidney disease or for diabetics on dialysis. The living donor can actually have the kidney harvested laparoscopically. So that's much better on the patient. They're up and around quicker. They're able to get back to work or functioning faster. They heal better. Used to be a big, horrible scar for any kind of kidney surgery, and now it's a matter of a smaller scar and a couple of punctures for the laparoscopic procedure. As far as kidney care post-operatively, now each time we look at this, we're going to look at the post-op nursing care and also look at the specifics for rejection surveillance. So as soon as the kidney is in and vascularized, lots of good output. So remember, if there's lots of output in a patient, they could easily get dehydrated and hypovolemic. So think about all those assessments. How are the electrolytes doing? How's the CBC platelets doing? There's a lot of monitoring related to the hypovolemia and then related to the kidney function. Sometimes if it's been, if it's been an extended time the kidney's been out of the donor, it might take a little while for the kidney to function, so they might need a dialysis treatment to give the kidneys a little bit of rest time, then they should kick in. Rejection surveillance for kidneys. It'd be tenderness over the site and decreased output. You can see everything there. If they suspect anything, it is biopsy. Now, the slide before this, they showed that the individual's own kidneys were left in place, and then the transplanted kidneys is kind of lower into the pelvic area, and that's kind of to protect the kidney and to just tap into the vessels, the veins and the arteries down there. So the kidney's not clipped out and replaced at the site, it's in a new site. Let me see if I've got my x-ray up here next. Not yet. Post-op education, patient education, medications. Again, some of the medications are harsh, so they might need to be on a PPI. Go over the signs and symptoms of rejection with them. And rejection, a lot of the rejections are the signs and symptoms that you had that told you that you had like kidney disease. Are they coming back? So it'd be they're getting a little bit of swelling on their ankles or hands. They're maybe not having the urine output they should be having. So all those like early kidney failure rejection symptoms could be signs of rejection. Activities related to the surgery more than the transplant. You can see those there. It's all about like not stressing the abdomen structures. And a dietitian is very helpful. They've been on their renal diet. You don't want them to go wild to eat everything they can, but it's all about sodium restriction, being careful if their appetite's stimulated to not gain too much weight. Okay. Oh, you know what? I have an X-ray of the kidneys, and when we get to pancreas, I've got a pancreas kidney transplant. So let's look at heart transplant. The end-stage heart cardiac disease, based on the New York guidelines, are the typical recipients of heart transplant. So these are due to severe heart failure. That would be the New York Heart Association grade 3, grade 4, and maybe some 3s. But all kinds of disease and disorders of the heart where the patient is barely functional and their cardiac outputs are diminished. So age limitations, again, same. They definitely do the ABO screening, but if the transplant organ can't last outside the body too long, so they might not have recipient donor screening as thorough as they'd like to. Some complication or contraindications would be additional liver and kidney dysfunction, and instead of lack of significant comorbidities, it would be significant comorbidities such as severe kidney and liver dysfunction. It's possible they could be a multiple organ, but if not, and they're up there in age, they would be contraindicated to have a heart transplant. Now, this is not a transplant, but this is an assistive device while an individual is waiting for a transplant. So if their heart status is poor enough that they're confined to bed, they're on oxygen, their outputs and perfusion are decompensating, they can put in this device which kind of bridges them to a heart transplant. And you can see that it circulates the blood around the heart and pulls it out into the systemic circulation. So it has a big assist to the left ventricle. So instead of the left ventricle flopping around and being unable to create output, the pump actually serves as the left ventricle. You can see that there's a pump that's outside of that's inside the patient, but there is a little battery pack and control system that lies outside the patient. So they wear this around. They have to be very careful with this battery pack and the control system. They have to change the battery regularly. There's a schedule they're on. They can't wait for it to start, wearing down. That would be a disaster. And then the rule is if they have to change their battery pack, they have to change it with someone else right next to them that knows how to change the battery. And it has happened that a young individual, gentleman, did not want to, always have his wife there to babysit him, and went into a different room and tried to change his battery pack and could not get the new battery in time. And the wife heard him fall to the floor and ran in there, but could not get the battery pack in time to save him. They took him to the hospital, but he had no cerebral circulation for a long time and could not recover, so that was kind of a terrible thing. But there's real strict rules to using this. Patients have to come to the clinic and be checked in intervals, and once a heart is available, they can be called to the operating room. So here's a depiction of the heart transplant. They have just big arteries and veins to deal with. You can see where they attach the heart. Sometimes it's, depending how it's attached, they might actually have 2 SA nodes functioning after transplant, but the donor transplanted SA node is the one that actually drives the heart process. Here's postoperative care. And they can have dysrhythmias. Any heart surgery can have dysrhythmias. There's the second P wave, and that's just kind of a phenomenon based on if the P wave, the SA node was salvaged out of the recipient. Cardiac output is what they're really looking at. How's their heart rate? How's their blood pressure? They might be on some vasopressors for a little while to help with cardiac output. They might have their temporary pacemaker there that's pulled after they're recovering. Rejection surveillance for the heart transplants are, they go into the cardiac cath, and they actually do like a cardiac cath, and they'll take a little piece of the cardiac tissue and analyze it and look for rejection. So this one, they don't wait to fail. They have to do the cardiac caths, and they have to identify how the heart is functioning. And at Good Sam, they had a patient, when I was there a couple of years ago, who I was in cardiac cath lab with the nurse, the student we were looking at, what's going on, what kind of action. Here comes this young guy walking into the cardiac cath lab, and as you know, they always are on a cart and wheeled in, and like, why is this guy in a gown strolling into the cardiac cath lab and jumping on the table? And they were all chatting with him and having a good time. Well, it turns out he was a heart transplant patient, and he was coming in for his cardiac biopsy. So he wasn't having an MI, he wasn't in danger, and they let him walk in. So everyone's waving at him and happy to see him. And that was the first time I've ever seen anyone walk into cardiac cath lab. So they look at the cells. If there's a little bit of rejection going on, they can start playing with additional rejection medication. The other thing the patient can do is, of course, they're going to look for fever, white counts. They need to be on their best aseptic technique. And if there's a fever, we have the term pan culture for any fever. We've talked about that before. If there's a fever and they're not sure where it is, the physician will write for pan culture, which means any place on the body that we can find any potential for culturing, we'll do it. That means we take a urine specimen. If they can produce sputum, yay. They'll do blood cultures, and if there's any incisions anywhere, they'll culture those. So pan means like everywhere, such as pandemic. So that's pan culture. Patient education, you see those there. If they're in there, then they reduce these surveillance to whatever it is, every 6 months or so that the cardiac team has them doing. But in between, if they start with any symptoms of heart failure, we have to have them come in. There's liver transplant, and this is irreversible liver damage that's progressive. And you can see that the criteria, if it's so severe, multiple body organs are affected, then they would not do a transplant. And again, the liver is kind of the least allogenic. here's our MELD and PELD. I won't have you look at those, but these are calculations that tell us who is our more severe and should be at the top of the waiting list. The nice thing with the liver is that we can take part of it because it will regenerate. Our nursing care, again, the all ever-present risk of infection. So we have rejection surveillance for this organ is fever or the elevated liver function test, those ASTs, ALTs. They only will biopsy if there's a suspected rejection because the liver is very vascular and they could cause a bleed. The liver also is in charge of our coagulation cascade, our coagulation function. So we have to do some careful examination of drains and lines, look for like abdominal swelling, tarry stools, post-operatively then hemodynamic stability because of the penchants for bleeding, and then all the liver function assessments. Additionally, we're watching renal function because as the liver has been in trouble, sometimes that causes renal function, and then as they heal with the medications, they could have renal disorders. Neurologic assessments are important because they clear up so dramatically. Before the operative phase, they might be very blunted cognitively, slow to respond, very drowsy, mentation is terrible. And then within a few days, 2 days, 3 days, all of a sudden, like the encephalopathy is being taken care of, the toxins are being cleared by the new transplanted liver, and all of a sudden they can think. It's great. Here's a depiction of a living donor, the right upper lobe, used for transplant. So on the left would be the donor, and they leave part of the liver in for the donor, obviously, and that regenerates, and the recipient gets a little piece, and then that regenerates. A pancreas transplant, typically these are kidney and pancreas transplants, so this is where I'll have a X-ray of kidney and pancreas in position. The 1-year survival rate is pretty good. Whenever you see survival rate addressed in percentage, that's telling you at the time that's stated, these are the percentage of individuals still alive. So that means at 1 year after transplant, 80% of patients have survived. Our goal is to eliminate the need for insulin. So it's not about amylase and lipase, it's about insulin and severe diabetics. So the age is a little younger. They do need cardiac clearance to have this. They don't want to have cardiac function. That's concerning. There's some of the risks there, and they're due to the risk of cardiac death. That's why they want the clearance. And you can see, like the kidney, when they transplant a new pancreas, it's low in the abdomen, like in the pelvic girdle. They attach the artery and the vein to the pancreas vasculature and get the pancreas functioning again. Now the problem is now you have the diabetes being taken care of, but where are the enzymes draining into from the new pancreas? So we have to do something to allow the pancreas to drain its kind of excoriating digestive enzymes. So here's the tricky part to the pancreas transplant. We'll look at that in a minute. The patient's pancreas left in place. Well, the donor, as you saw, is low in the abdomen, but now we have to create a drainage portal or a drainage system for the exocrine or the digestive enzyme function. So either they'll take a little piece of the duodenum and attach it to the head of the pancreas, and then attach the other end to the top of the bladder or to the bowel, so that the enzymes can drain either directly into the bladder or into the bowel. So if you think about it, if it's going in the bowel, that's where the enzymes typically go, and they won't have as many complications for that. But with the bladder, now you have digestive enzymes being moved into the bladder. So that could be problematic. The bladder anastomosis, though, when we do this, we can also see if the pancreatic enzymes are still being created, and that means your pancreas is still healthy. So if your pancreas, if the enzymes start to fall, the levels start to fall, that means your pancreas is getting rejected or not functioning well. So that's a rejection surveillance for the pancreas. Let's look at our next slide. So here's the two types of anastomoses. We can either use the bowel to the head of the pancreas, or a piece of the bowel to the head of the pancreas, and then to the top of the bladder. So again, the one on the top mimics the typical emptying of the exocrine enzymes into the bowel as usual. The other one empties the enzymes into the bladder, which can cause bladder irritation. But now we can also test for the, use the urine like a dipstick to test for the enzymes. So post-operative monitoring, a lot of it is related to diabetes. So they initially might just be on a insulin drip for 24 hours, allow the pancreas to rest until it's starting to stimulate insulin function on its own. If the bladder diversion is used, then we need to make sure that they don't get dehydrated, which would concentrate the amylase and lipase in the bladder. We need to make sure they either irrigate their bladder post-operatively, we set that up, or make sure they're really hydrated by IV hydration. As far as post-op care and family education, here's our rejection surveillance. If the bladder diversion, we look at the pancreatic enzymes. Otherwise, we're looking for fever, tenderness in the lower abdomen. But if the pancreas is failing and they become hyperglycemic, which means their insulin production is down, that's actually kind of a late rejection sign. So we have blood glucose monitoring, ultrasounds, those are all very good. Now here's a depiction of the pancreas and kidney transplant at the same time. So this is where you can see it says allograft kidney on the right, and that would be where a kidney transplant typically is, again, down in the pelvic girdle. And then there's our allograft pancreas, which looks like it's attached to the top of the bladder. That's my guess. Don't quote me on that. But you can see that's located low in the abdomen. And they're not the white, it looks like it's mostly bowel, like loops of bowel. But look carefully at this and you'll see the position of the kidney and then the position of the pancreas lower in the abdomen. A couple other transplants. There have been some face transplants, and if you look at this one carefully, you can see from between the eyes, the bridge of the nose, all the way down underneath the jaw, this individual had that part of her face actually bitten off by a dog. And this lady is from France. She was one of the first face transplants. And you can see there's not a lot of muscle coordination of the lips, but she recovered quite a bit of function. I think this was from about 15 years ago. She has since passed away. But there are some additional face transplants out there now that have either had, devastating gunshot wounds, or one was someone was electrocuted in the face by falling into some high tension wires, like a lineman for one of the electrical companies. These are not like wildly rare, they're not very common, but again, we have talked about the skin will suffer rejection at some point. And there recently was an article in the paper from a woman, not this one, who had had a face transplant due to a terrible accident, and she was just now starting to have rejection, so she was going to lose her transplant. They were going to have to look into prosthesis or something. But she says, I am so glad I had this done. It gave me multiple years I could be in public, that I could enjoy my life again. And even now, you know, I'm not, now that I'm undergoing some rejection, I'm just so grateful to have this happen to me. So it's a very interesting article. Another transplant, there's some hand transplants, arm transplants. You can see, you know, it looks pretty good. They have kind of gross motor movement, not a lot of fine motor movement afterward, but they're able to use their extremity. There are eyelash transplants. Don't ask me about this one. I just found that and put that up there. But this is more for like patients. This was an article for patients talking about having alopecia, so they had no eyelashes, no eyebrows. This is, sorry, an eyelash transplant. And that, I believe, is it. This is the end of our transplant information. I will, sorry I'm over an hour. I thought I'd be about an hour. And then I'll be posting the rest of the presentations over the next few days. Have a good day. Have a good afternoon, wherever you are in your day. Again, everyone stay safe, and I'll be talking to you soon. Bye now.